Recanalizations occur usually at day at 22 weeks, whereby the failure of the paramesonephric duct to fuse. And we have another issue, which is the failure of the sino-vaginal bulb to recanalize. So it's failed. Then we have a transverse vaginal septum. And if the vaginal plate failed to recanalize, then we have the imperforated hymen. Imperforated hymen. And usually both patients were present with cyclical abdominal pain because of hematometra or hematoculpus in case of the imperforated hymen. So what I want to share is actually this is the uterus. This is the ovary. So the blood supplies. As we know, the blood supplies of the uterus. So we have the abdominal aorta here. We have the renal artery. Yes, so we have the ovarian artery. So ovarian bilaterally comes from the abdominal aorta. And we have the external iliac artery and internal iliac artery. So as the internal iliac artery divides into anterior and posterior branches, so the posterior branches will divide into SIL, the iliolumbar, the laterosacral, and also the superior gluteal artery. And what gives the blood supply here is from the anterior branch, this posterior branch of the internal iliac artery. So as for the interior, we have, first of all, we have the inferior gluteal artery, and then we have the internal pudendal artery. Down after that, we'll have the what we call a middle rectal artery, and then we have the uterine artery, and we have the vaginal artery. And after that, we have comes into the obturator, and we have the supravesical giving to the bladder, and we have lastly the medial umbilical, or we call it obliterated medial umbilical artery. This is the remnants. So basically, the understanding of the vessels is important because it's very important in the systematic pelvic devascularization, whereby we have to stop the bleeding in case of the PPH by ligating the uterine artery, and then ligating the ovarian artery, and systematically try to ligate the internal iliac artery. And what about the innervations? So the innervations of the vagina and also the the superficial perineal area is coming from the pudendal artery. So S2 to S4, it's coming from the sacral plexus. So it will divide itself and become the perineal nerves, the posterior clitoral or posterior penile, clitoral. This is perineal, and this is the inferior rectal. So this will innervates the what we call an external anal sphincter, And also here it will stimulate the external urethral sphincter, and also here is the vagina. Okay, that is for the innervations. And what about the lymph nodes? As we know, the lymph node is very important, especially when we talk about the gynae oncology, because we want to know the methods of the disseminations of the disease. So we have ovary here. As for the lymph nodes, as we know, the fundal, the fallopian, and the ovarian will drain out to the para-aortic lymph nodes. The ovarian specifically will go to the lateral aortic or pre-aortic lymph nodes. And the body and also the cervix will go to the internal iliac nodes or external iliac nodes. And the vagina, since the origin is also different, so lymphatic also different. As for the lower 1/3 of the vagina, it will drain out to the inguinal lymph nodes. And the upper 2/3 of the vagina, it will goes to the internal iliac nodes. The favorite question is about usually the para-aortic and also the inguinal, because it's quite clear the distributions. Okay, so let's go to the what we call the POP. So as we know, or before we go to the POP-Q, let's talk about the Delancey support first. But before that, I just try to simplify things. So we have the urogenital triangle. And also we have so at front we have the urogenital triangle here, and we have the anal triangle. So the urogenital triangle basically composed of the urethra and also the vaginal opening, and the anal triangle will compose of the anus. So what we have here, the muscles that contribute to the urogenital is first the ischiocaverna, the bulbospongiosus, and also as for the anal triangle, we'll have the pubococcygeus, different color. So we have a pubococcygeus, puborectalis, and also the ileococcygeus. This one is puborectalis. And we have pubococcygeus. And this is what we call an levator ani muscles. That is for the muscle support. But what about the ligaments? So for the ovarian, we have the infundibulopelvic ovarian ligament. Also for the uterus, we have the round ligament. So for the lower part, we have this is the urethral opening, this is the vagina, this is the anus. So here we have the cardinal ligament, We have the pubocervical, pubic, and cervix. So up here, just imagine there's a uterus and also cervix. So we have the cardinal. We have the pubocervical ligament. And at the back, we have our famous uterosacral ligament. So this is basically the understanding of this is important for the POPQ. As for the POPQ, let's say this is the 0, where we have the hymen here as a landmark, or the urethral opening. So we have the vagina canal here. We have the uterus. So we have the anterior and we have the posterior point. So on the anterior point, we have the point A and point B, and we have point C here, which is A is actually 3 centimeter away from the hymen. So this will be negative, and out from the hymen ring, then it will be a positive to show the prolapse. So AA is 3 centimeter from the hymen or urethral opening, and BA is actually the most prominent part in between the AA and also the C, and C is the cervix. And we have here, which is the middle compartment here, we have the GH, the genital hiatus. We have the perineal body, PB, and we have the total vaginal length, TVL. So at the back, the same thing, we have A point and B point of the posterior parts, 3 centimeter from the hymen as well. And for the B part, the most prominent in between the D point and also the AP. So what is D? D is the uterosacral ligament incisions at the cervix. Okay, so the POPQ, the basics will be anything less than 1 centimeter from the hymen. We call it stage 1. And in between 1 centimeter in and 1 centimeter out from the hymen is stage 2. Anything TVL, total vaginal length, minus 2 centimeter, less than TVL, minus 2 centimeter is stage 3. And anything more than this, TVL, minus 2 centimeter, will be stage 4. And what it tells here is actually the Delancey support, whereby we have the 3 levels of support here, level 1, level 2, and level 3. So let's go for the level 1. Level 1 of the Delancey support, talking about these ligaments, which is the apical support. So the apical. So they due to the weakness of this ligament will cause the apical prolapse. So as you can see, the level 1 is the apical prolapse. So the treatment will be the sacral fixations. Depends. If it's a after the vagina hysterectomy, then we call sacral colpopexy. It can be abdominal or laparoscopically, sacral colpopexy, or we can do SSF, the sacrospinal fixations. If the Delancey 2, basically the weakness is at this point, whereby the weakness is because of the ATFP, the aqueous tenderness of the pelvic fascia. So the treatment will be this is the mid cavity. So the treatment will be the anterior and posterior repair by using the Cayley's or buttress suture to strengthen the anterior and posterior wall. And the level 3 is also basically the superficial perineal. So we can have the urethrocoel or rectocoel. Urethrocoel or rectocoel. Okay, so that's for the Delancey support. And yeah, we have what we call a deep and superficial perineal membrane pouch. So we have the deep and also the superficial. So what's actually contained in the superficial perineal pouch is basically the bulbospongious muscles, the ischiocaverna, and also the battling gland, battling cyst. And what inside the deep perineal is the bulbourethral, and also anything above this perineal membrane.